YouTube. Once you are live, just let me know.
Just instruct me how to screen and project the PowerPoint actually.
Okay, okay. Ahalya, you can wait for some time. So,
Yeah,
sir, at
okay.
the bottom of your screen,
I
you
have
can see
minimized
this.
that. I have minimized that.
You should see that, sir. Actually, there is an option like audio, video, raising that hand, and
Yes,
next
yes.
to that
Raising the
there
hand
is
is there. Yeah,
next to that there is present now.
correct, correct.
So
Yeah,
you can
yeah.
click on that present now, sir.
Okay, okay. I'll do
And then
that
you,
once everything okay. Right.
so okay, okay, sir. Means okay. So okay, Ahalya, we can like go live.
Okay, sir. We are live now, sir.
Yeah. So namaskaram and welcome to all the participants. Thanks for taking your time and joining us today, and especially thanks to Dr. Samal sir who has taken his time out of his very busy schedule. So on behalf of all the participants, I welcome you, sir. Uh,
Thank you.
and just to keep it in one sentence, if I'm alive today and talking to all of you, it is only because of me meeting Dr. Samal in 2004, close to like 20 years back. So I has requested sir to have a talk with all of you, and sir graciously agreed for that. Nikita, you can introduce sir, and then sir, you can give your talk after the introduction is over.
Good evening, everyone. I take great privilege in introducing today's speaker, Dr. Subhash Chandra Samal. Dr. Subhash has done his graduation and post-graduation in internal medicine from Sambalpur University, Odisha. Sir has done his doctorate in medicine in gastroenterology at Christian Medical College, Vellore. He continued as a faculty in the same institute after completing the DM program. Sir has worked as a consultant with Apollo Hospitals, Hyderabad. Later, worked as a professor and head of the Department of Gastroenterology in Jipmer, Puducherry. He is presently holding a post of professor and head for the Department of Gastroenterology, AIMS, Bhubaneswar. Sir has more than 60 publications in national and international journals. His areas of interest are inflammatory bowel disease and interventional endoscopy. I here welcome you, sir.
Thank you. Oh,
Sir, you can click this
yeah,
present
I
now
just
option,
I click now.
and then you will get the entire screen.
Share. I'm clicking the share. It's not coming back.
So select this option entire screen, sir, and then it opens.
Yeah, yeah, I did that.
And on the screen means you should tap, click on that screen, sir, which you find there.
Can you see now? No,
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 sir, no.
no. Okay, just one sec. So I should click entire screen, nahi?
Yes, sir. Yeah.
And or should I half open the new window then enlarge it? I'm not sure.
Yeah.
Okay.
Once you select that entire screen, actually, then later you can open
Okay.
your
Okay.
presentation, and that basically your entire screen will be seen, sir.
Once I put entire screen, the screen which I am seeing that is coming only. Like you guys are there. So just one second. Try it out.
Or you can forward it to me, sir. I can share the screen and
Okay,
maybe
okay, 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 okay.
that will be.
Now you got it?
Yes, sir. Yeah, we
Yeah, I
can see.
got it.
Yeah.
Okay.
You can click on the bottom. You will have that full screen icon, sir. You can.
Okay. No, it doesn't matter. Right?
Okay.
Can you see the full screen now? I mean,
No,
full
sir. We
screen.
can.
Not.
No, sir. So at the bottom it says 100%. Beside that there is a icon. If you click it, becomes full screen.
No, I'm seeing right now full screen. So
Okay, so I think yeah, we will
no.
go
So
with
I
this.
do that. No, not yet.
Yes, this is okay, sir. We can like
Right now,
go.
I'm just enlarging it. Just see.
Yeah, yes. So that
Uh,
icon. Yes, click on that icon, sir.
okay. Can you see now? No. I got the full screen here.
Uh,
Anyway, so whatever
yeah,
I'm just mailing you right now.
yeah, that's okay. I think this is also okay, sir. We can go with this. We can still see the screen, not the full screen, but it is okay, sir.
Okay. Should I start it now, Karthik?
Yes, sir. Please.
Yeah. Uh, good evening, everybody. And thank you, Dr. Karthik, for this opportunity. This is a topic which is close to my heart, and I was thinking to do a project, but I didn't get the opportunity to start it. But I think, and I found certain works being done internationally, so I thought I could present before you. Inflammatory bowel disease quite often you see. It is the prevalence and incidence are rising not only in the developed country but also in the developing country. So the people have tried to explain why it is rising, and the so-called hygiene hypothesis they put forth to explain the increasing incidence of inflammatory bowel disease. And this hygiene hypothesis is almost 30 years old concept. With passing of the time, with industrialization, increased financial status or improving financial status, improved with hygienic status of people, they found there is increase in prevalence or incidence of the inflammatory bowel disease. Basically, this is what happened if during the childhood period, if anybody is not exposed to particular sort of bacterial population or viral populations, if the same child exposed to them in the future and the reaction is violent and something altered reaction takes place. And moreover, the exposure in the childhood to this particular bacteria or particular virus develop a tolerance to the particular immune process. So later in life, they do not develop the same heightened reaction of immunity to particular virus and bacteria. So that probably prevent the inflammatory bowel disease in future, where people are exposed to unhygienic situation in the childhood. But however, the disease etiopathogenesis so far is unknown. Even if we know this is multifactorial, including environmental, social, genetics, transcriptional, microbial, and dietary and immune factors, but still we're not being able to explain the exact etiopathogenesis of the disease. Diagnosis is basically made by clinical history, investigations, biopsy, blood test. And despite all those diagnostic facility tool we are having, but it's not straightforward one. Sometimes the disease which diagnosed ulcerative colitis can change to Crohn's latter part in 5 to 10% cases and vice versa. And some cases, some people behave differently. Some cases recover quickly. Some people do not recover, develop complications. We do not have answer to all those questions. This is variable course, unpredictable response. We do not know why it is happening. At the end, still the response to treatment is not very good. It is really modest one. So these are various questions in mind while dealing with inflammatory bowel disease. So I thought, let's see what is happening, why it is like this. So my talk I'll divide into basically 3 parts. Part 1, I'll give the glimpse of what are the treatment available. Part 2, I'll explain why should we change it. And part 3, I'll tell how do we change it. The current therapeutic paradigms with got it is basically to start with. I'll start as salazopyrin. Salazopyrin is basically a very old medicine, and all of you, the students of pharmacology, must be knowing this is discovered accidentally. Salazopyrin initially used for rheumatoid arthritis, and they found after giving salazopyrin people, those having diarrhea, they improved. Then later on, it was introduced as a treatment for the inflammatory bowel disease. And this is once upon a time the only treatment available for the inflammatory bowel disease. Nowadays, this is only useful in very mild cases of ulcerative colitis, so no more being advocated for use in very severe cases. Then,
Sir, sorry to interrupt. Sir, are you trying to change the slide, sir, or you want?
I'm changing it.
Actually, we can only see the initial slide. At least
Oh my goodness, what will do? Just one second. Maybe it is not. Just 1 second. And so.
Yeah, now we can see the biological slides.
No. I'll just it is introduction.
Yes, yeah. Now we can see the introduction. Yes.
So I think if I make it full, we are not able to see. I'll change with this only.
Okay.
Let me. Okay. So we have salazopyrin, which is coming back in 1940. Then steroid, the next line of mainstay of therapy for IBD is corticosteroid. And initially, it was a main medication used for treatment of ulcerative colitis, Crohn's disease. And later, it was found long-term continuation of corticosteroid is not very helpful because it has a lot of side effect. So that is the reason it is only used for induction of remissions, not for maintenance. The third line of drugs which came during 1960 is azathioprine and marcaparin. This medication basically used for the cancer. It is immunomodulator. So subsequently, it was found to be useful in IBD, but only again, this is used only for the maintenance of remission, not for inductions, and it takes long time to work. The other medication which less frequently used are cyclosporin, methotrexate, and tacrolimus. Between late part of 80 and 2000, antibiotic was at the headline of the newspaper treatment of the Crohn's disease and ulcerative colitis. A lot of antibiotic being, listed for that during that period for use, like azithromycin, quinolones, metronidazole, etc., etc. But none of them found to be very useful and have a very minimal benefit. So it is again went out of the favor. However, certain situations where antibiotic can be used that is called pyocytis, perianal Crohn's disease, and following surgery for Crohn's disease. Then the next is probably pro and prebiotics. So a lot of research interest right now is going on regarding microbiome and this probiotic because the safety profile is very good for these two agents. But again, there is no evidence, very robust benefit out of this. So this is still is not a main form of therapy while treating the inflammatory bowel disease. Presently, the main treatment or the central role played by the medication for treating bowel disease, inflammatory bowel disease, is biologics. What is biologics? Biologics basically it is a protein, and it is a monoclonal antibody directly against inflammatory marker, or you can say something which is responsible for this. It is a basically monoclonal antibody prepared against various cytokines. That is called biologics. And at present, that can classify into 4 types: anti-TNF, anti-trafficking agents, and ustekinumab, small molecules. Anti-TNF is the main molecule right now being used throughout the world for treating inflammatory bowel disease, including Crohn's, ulcerative colitis, and this. Anti-tumor necrosis factor, anti-TNF, the main medicine or the main agent under this heading is that is called infliximab. Again, the response is not that very good once you start the treatment. So at the end of 54 weeks, response is 25% in case of UC and 35% UC and 25% Crohn's disease. The next agent is adalimumab. Again, this agent is usually used by subcutaneous injections, whereas infliximab is IV injections. And again, the response is hardly anything beyond 30%. The other two agents is golimumab and rituximab. There, both agents are being FDA approved. This for golimumab for the UC and cetro for the Crohn's disease. When we found the inadequate or suboptimal response to this medication, then it was found out that the certain things we can do to improve the response. One is either you can combine these agents with immunomodulators, or sometimes you can use therapeutic dose monitoring. Once you find the dose is adequate or inadequate, checking the blood level, that also can improve this outcome. Despite all those effort by you combining with immunomodulators, checking the dose level in the drug level in the blood, therapy failure and side effect are the major concerns. Then the other things which come in the picture, biosimilar, again, biosimilar is similar drugs, similar efficacy, similar side effect, less costly. Maybe I'm not discussed all this. Biosimilar also more or less same as the original molecules. The other group of biologics is anti-trafficking factor. Anti-trafficking factor this is basically a neutrophil. Normally what happens, this neutrophil, once there is inflammation, the neutrophil comes and join in the intestinal tract and carry forward the damage further. And this endothelial cells and the leukocytes, mediation or the attraction takes place by a molecule known as alpha-4 and beta-7 integrins. These molecules, the antibody against this binding site known as anti-trafficking factor. The main agent being used is vedolizumab. The advantage of this agent is basically it is a intestinal specific. It only works on the intestine. It doesn't interfere any leukocyte trafficking in any brain or any other sites. It is side effect little less than the previous one. The response rate is better than 42% and 32% respectively in UC and Crohn's disease. The third agent in the list is ustekinumab. Ustekinumab basically is a IL-23 receptor antagonist, and 52 weeks response rate is almost 44 and 53% respectively. The side effect profile almost same as the previous agent. Recently, one small new molecule has come to market that is called JAK inhibitor, Janus kinase inhibitors. It is oral medication, unlike the previous, which is given in injection form, this oral form. And this is again response rate not very good. But only thing is given orally, and side effect profile is not very good, worse than the previous agents. So at the end, if you find overall performance, the overall performance is 20 to 50%. If you take out the placebo response, 7 to 30%, so it is not very good. All those agents are not up to the mark. And this biologics is not a magic bullet. Moreover, 40% lose response over time. And despite having biologic therapy, 11% of UC patients require surgery during their lifetime, and 70% of Crohn's disease patients require surgery. So that is what is it? That is the current therapy. Then what is the new agent? What have come recently? It's recent therapy. So there are many agents like biologic agents are in pipeline, one phase 2 or phase 3 trial, and there are orally administered small molecules also being developed. As I told, the JAK inhibitor named tofacitinib, I will 5 in 10 milligram. I will not talk in detail. The response rate of this JAK inhibitors is 34 to 41%, low safety profile. And anti-TNF oral formulation is, people are working on that. It is already available for therapy. And anti-trafficking agents, unlike trafficking against the neutrophil, right now we have anti-lymphocyte trafficking agents, that is adalimumab. But again, this we do not know the efficacy of these new agents. There is a trial phase 2, 3 trial is going on. But I don't expect there will be much improvement, because all of them almost target similar pathways, hence the low chance of high effectiveness. If you see the real life effectiveness of all drugs in market, you put everything, it is almost 5 to 13%. So the promise and potentials for this medication presently what I use are limited. Of course, people can try 2 agents simultaneously having different target, combination therapy, and early data started coming to literature, and its early data is almost 50%, but it again long way to go. We do not know how much it to be. Combination therapy. Apart from medications, what are the other therapy available for IBD? All we have seen, the 90% drugs is almost immune related. What about lifestyle modification? Stop smoking. Again, it's not very much effective, but it works. People those who eliminated diet, again, Crohn's disease, it works, but again, if patient do not stick to the diet, it's very difficult to stick to this diet therapy. Exclusion form of diet, some people avoid wheat, dairy, emulsified dextrine, and sulfides. So these all measures help, but not to the extent that we expect. And stem cell therapies is coming up using IBD. This is basically useful for the perineal fistula, and result is almost same as biologics. Of late, the called fecal microbiota transplantation. There is some promise, but it's long way to go to establish its position as a mainstay of therapy in IBD. The question comes, why to change the therapeutic approach? So far we have seen existing therapies are not very effective. And IBD basically is complicated. So it has 4 major components through which, or these 4 major components responsible for this disease to manifest. You can say 4 ohms. You can say exposome, genome, microbiome, and immunome. What is the exposome? Exposome is basically environment. It is both external and internal environment. And genome is the personal gene, DNA of the host, and host genetic makeup known as genome. And microbiome, all of you must be knowing. This is basically bacteria, fungi, viruses in the gut of the human being. And the immunome. Immunome is both systemic immunity and mucosal immunity, both together. So these are 4 ohms responsible for the development of the disease progressions, behavior, response to therapy, etc., etc. And the exposome, as I told, this is basically environment. It's extremely complex, and it changes environment. It keep on changing continuously. It is very unpredictable and impractical to qualify and hard to quantify. Genome, again, it's stable, individualized, it's qualifiable, but its function depends upon other genes and exposome. Microbiome is complex, varies continuously in the individual. It is individualized, it's hard to quantify but difficult to qualify. And microbiome mostly depend on the diet, antibiotic, xenobiotic drugs, and etc. Immunome, again, it is highly complex. It constantly adapts to the immune and metabolic signal. Partially qualifiable, it's hard to quantify, and it is mainly affected by the exposome, genome, and microbiome dependent. Besides all those things, whatever I told, the 4 factors, human beings are different. There are different components acting differently in each patient. Different receptors, different signaling molecules, different DNA, which express and transcribe different genes, and ultimately translate different proteins and produce distinct pro-inflammatory product. So end result is, despite having all the different elements, end result is damaging inflammatory process, that is IBD. That we know. So it is complex. Why not embrace its complexity, look for different means to treat it? So whatever I put in pictorial form, this is again, for example, 3% is red, green, and this is pink color. And this is there person A is exposed to again exposome, genome, and microbiome. But here the exposome is different than the person B. And person B exposome different person C. So each case exposome is there, but again different for different persons. Similarly, genome, microbiome also. And once this is different, again the triggering factor will be different for different person at different level. Once the triggering factor is different, then the signaling molecules also will be different, and the transcription factor different. Ultimately, you get a pro-inflammatory product. At the end, we get the pro-inflammatory product, but the path is different. Individual differences there, molecular differences there, pathway is different. So it is not very easy to comprehend and put one drug, one medicine for one disease. So predictive approach, if when you treat an IBD, you ask yourself, am I treating a disease or am I just treating the inflammation? Probably all of us right now are treating the inflammations. And a decade ago, this person told once again, when primary pathogenic events are unknown, better control inflammation is sometimes the next best options. So right now, at present, 90% medications are basically we treat only the inflammations. And gene therapy, suppose gene is responsible. So far, IBD, we do not have any for gene therapy. And exposomes like environment, smoking and diet is manipulated to some extent, but again, it's not very effective. Microbiome, diet, probiotics, again, it is infantile stage, and fecal microtransplant, again, it does not come up to the expectation. So we are left with no other option except this 5-ASAs, steroid, anticytokines, anti-receptors, blocker, leukapheresis, etc., etc. So these are all available, and these are all we are treating with these agents. So putting this in graphical form, if you see, 90% are immune system we are treating with. 10% only microbe-based treatment is there, 5% environment-based treatment, 0% genetic-based. So obviously, once we concentrate only one aspect, there will be failure. When the disease is controlled by various multifactorial disease. Then how to change it? Change the therapeutic approach to inflammatories. Avoid single target and single medicine model to be avoided. IBD is complex and multiple components and multiple links. For example, suppose there is a various type of network, social network, financial network, marketing network, political, business, computer network. Think of this as a network. And we have to have a network medicine approach. Accept and rely on many different type of networking process in the pathogenesis of this disease. So this is basically network medicine. Incorporate all pathogenic component into unifying functional entity. That is called IBD interact. Because all IBD is nothing but the interaction between all the 4 factors. Out of this, we'll get numerous biological components and use technology to dissect this biological component. What are the tools we have? We have transcriptomics, proteomics, epigenomics, single cellomics. These are all tools we have. Dissect all the biological components, give the data, analyze and unify this data by computational modeling. And there will be massive amount of data available, and this requires artificial intelligence to analyze all this data. How it works? Suppose you get data. Any networking, there is a hub. There is a periphery and center the hub. Once you attack the hub, entire system will collapse. So any network system in an IBD network, there will be hub. This hub is again centrally located. If the hub is disabled, the disease is eliminated. So IBD network is basically composed of genes, environment, microbes, immune cell, etc. You analyze that, break the biological component, put in the use artificial intelligence, find out the hub and target the hub. Diagrammatical this representation. This is again in figure A. You find different factors networking there, and you hub is there. If you treat peripherally, like here, drug 1 use effect is very minimal. Drug 2, some effect, and you find drug 3 immunosuppression is little bit effect. If you find biologic little bit closer to the center, better effect. And if you try to attack the hub, if an entire disease process is cured up, and you'll find a complete cure rate. So this is the basic concept of networking IBD, this thing treatment. How do you implement? First step is biosampling. Sample the all biological fluid, including the stool, blood, tissue, urine. From whom to collect the active, inactive, and healthy controls, and subject them into multi-omic analysis, genome, epigenome, transcriptome, microbiome. Identify each ome's molecular networks, integrate these omics data using artificial intelligence, and generates IBD network. During this artificial intelligence generating networking, identify the hub of each network. Once you identify the hub, it will not be difficult. Identified hub becomes the molecule to be therapeutically targeted. So it is a computational docking platform to crystal structure of the target used to generate the small molecule inhibitors. And these molecules should be tested for the toxicity, safety, overall best is clinical tested. And this should be the moleculars of getting specific as well as patient-specific drugs. And once, I think this is my last but one slide, to conclude, this artificial intelligence-based multi-omics analysis of these various components drastically will change the approach of IBD treatment, and probably this will implement of the precision medicine in treating the inflammatory bowel disease. Thank you all for your attention.
Thank you so much, sir. So honestly, I developed a lot of interest in knowing about my own condition after listening to you, and I realized that before a doctor writes a prescription for patient, how much of a background knowledge goes into your mind thinking about all this aspect before you put a word on prescription. So sir, any message for students? Actually, after some time, I want to stop the live stream and have like a closed discussion where I want to talk about few more things. But before we do that, do you want to give any message to all these budding students?
This is, I mean, your student, young mind. So basically, I'll tell them, believe in God. Let me take an example of my son. So I had a little argument with him. Right now he's in the UK doing his economics. So he told, why should I? He doesn't believe in God. I told, why? Last time I told, no, if you told karma, if I'm doing my karma, why should I beg somebody to give me something? Then I don't know, you do your karma. So what is the use of then calling God and praying God and asking him to give something to me? I don't want to ask something from somebody. Then I just gave him one example from Bhagavad Gita. So I told, in Bhagavad Gita, when Arjun, I think Arjun went for Swayamvar Draupadi. So he has to, so there is a condition that he has to put an arrow into the fish's eyes, which is rotating up, and he has to see the down into the water, see the image, and put the arrow. Then Arjuna asks Krishna, I'll do everything. Why you are taking credit? I'm capable of doing all those things. So why should you want me to? And Krishna told, okay, you can do everything, I understand. But what about the water? Who will keep the water still? If a little bit of air, you can't see the eyes. So my job is to keep that thing steady for you. So that is called X factor. So my point is, you read, you work hard, but everything you surrender to him, your result will be definitely good, and you'll achieve everything. So by praying him, dedicating your work to him, that add a lot of things to your life. The other thing regarding some people feel presence of God, it is there or not. You don't have to see him, you have to feel him. And one or two incidents I'm telling from my life, long back, that was in Punjab, Khalistan movement was going on, 84, 85. I supposed to travel to PGI Chandigarh. After my MBBS, there was a MD entrance. That time, flight was not there, train was not there, only bus available from Delhi to Chandigarh. Every time you go to ISBT, catch a bus, go to Chandigarh. and that was one day to evening 7:15. I think I remember evening. So I went to ISBT. I just went up to the bus, booked the ticket, sat in the just behind the conductor seat. Then somehow I feel I'll go for next bus. In fact, I did. I came out. I didn't ask for money. I came out. I went to next bus. So next day, next bus I went and reached in the early morning. The next day I saw the particular bus which I came out was completely blasted by bomb. And 20, 30, all of them almost died, everybody. So sometimes you feel somebody there to always to take care of you. So you call him or don't call him, but always there is somebody to take care of you. Another incident again in Hyderabad, since Karthik, it is happened in Apollo. That time, month of December, one guy, a white person, American, so he came for colonoscopy. He's a very, very, very VVIP. He is the American embassy representative. So he told, because this December Xmas, I don't want to go to USA. I didn't get a flight ticket, and I want to get my annual colonoscopy done because they have every year they get colonoscopy done because of pollen. I take it. Then all the American, they don't want to undergo colonoscopy without anesthesia. So I called anesthetist came and gave anesthesia. Yes. I did a colonoscopy. After colonoscopy, he developed hypotension, low blood pressure, respiration stopped. I was shifted to ICU, intubated. Then I was told that by my colleague and hospital that patient has complications. Something happened. You probably during the procedure you miss up might have happened. I don't know. I have to be very careful. Nothing. I'm pretty sure nothing has happened. But anyway, investigation was done. Everything was normal. I really didn't know what is happening. Went back home. I cried and I really literally cried and prayed God, what has happened? Why it can be this problem? Why nothing? I didn't do anything. So if the person dies, I'll be in jail next day. I got not a dream. Somebody told me, why don't you give him IV steroid, hydrocortisone? Then that went to 12 o'clock at night. My resident was there and I called him. I told him, just give hydrocortisone IV 6th hourly. We'll see. And next morning, I went to OPD. I had to said that patient is all right. He's extubated. Then experience also came to mind. Experience came means then I know he was giving propofol and the anesthetic agents, which is usually they use egg white as a preservative in anesthetic agent. And people, those who are egg sensitive, hypersensitive reaction develop. And this drug was given IV. And the person had developed hypersensitive reaction to this. Right? I thought probably I was told this thing by one of the anesthetists. I remember and told him that I called the anesthetist. Hey, you told me this drug can. No, sir, I never told you. I also didn't know that drug this contained egg albumin reaction. How do you, actually certain came to mind. So basically, there's always somebody to help you, and just believe him, pray him, surrender him. Whatever work you do, just give it to him. So my message to this young mass is, you will do whatever, but always have faith in Almighty. Thank you.
Thank you so much, sir. So we will take a feedback, sir, from students. Like we have 226 in this meeting and many are watching on YouTube also. So does anybody want to share your feedback with sir, what you felt? Not just the talk, but the final examples which sir gave.
Good evening, sir. Myself, Sapna sir, studying fifth year pharmacy. Thank you so much, sir, for taking this session. Everything was clearly explained, sir, like with diagrammatic representation, pie charts, the need to change the therapy, new treatment approaches. Everything was very well explained, sir. We understood it clearly. And the implementation of precision medicine is really great, sir. Thank you so much, sir.
So anyone? Yeah, Hemashri.
Yeah. Uh, First of all, good evening, sir, to both the Karthik sir and Raman sir. So, actually, Karthik sir has mentioned you several times to us that you really helped him come out of his dark situation. And after today's class, I realized that doctors put so much efforts before they do something like as sir said, you have so much research in front of you and you have to take up that and still apply that. It takes a lot of time. You have to go to rounds, op and all, but you still manage. That's why I think doctors are called superhuman beings, and we are glad that we met you, sir. And again, about what you have told later in the session about believing in God, I think people who have experienced such conditions can actually believe in God. Like I have gone through a similar situation that it was life-threatening issues. I had an accident in my very young age. My complete jaw got shattered. So it was a very hectic moment where my mother literally begged the doctor to take all the jewelry she has and save me. So I think that is why the God Himself comes in the form of doctors, and that is why we believe so much in doctors, people like you, and also we keep our prayers in front of God. Thank you so much, sir.
Thank you. Thank you for your kind words. Karthik, unmute yourself.